Hi everybody, visiting us from the NOCD landing page. I am Stephanie Lonsway. I am a clinical psychologist in Michigan and the NOCD Clinical Director. I've been with NOCD for coming up almost on a year here and was really excited to be working with them. I've been in private practice for almost 5 years, where the majority of the clients that I see have OCD as their primary diagnosis, and as I'm sure many people have experienced, it's hard to find a provider and get in, and so I was excited that NOCD was willing and excited to tackle the idea of getting more people trained in how to treat OCD and to improve access to care. So those are some of the things that brought me to that, and just to give you a little bit more background about myself, I think it's been 10 years now that I have been treating individuals with OCD. I started at Northern Illinois University in my graduate program as part of their training program, and we just have people in the community who would come into our clinic with symptoms of OCD, and luckily I worked in the anxiety research lab there, so we got a lot of training and intensive supervision and working with those individuals and doing observations about exposure and response prevention. And from there, I got the opportunity to go work with Telehealth. If anybody from Illinois has heard of them, or from the Midwest, hopefully beyond, has also heard of them. They have IOP, PHP, and residential programs for individuals specific to OCD. So I worked with them, and their director, Dr. Patrick McGrath, mentored me for about 4 or 5 years, on and off, where I would go out and do practicum experience, which meant I would do actual therapy with their clients, and I also worked with them doing research. So part of my dissertation research actually came out of individuals who were in their program there. So from there, I went on to the University of Michigan, where I had a really great time, again, getting more intensive supervision, working with individuals and doing exposure and response prevention for OCD and then other anxiety disorders as well, helping run groups for people with social anxiety, mindfulness-based cognitive therapy groups, and had a lot of different types of theoretical orientations that I was introduced to. But exposure and response prevention is my primary approach that I use with OCD, and kind of excited to be talking to everybody today and hear more about what you're looking to learn about OCD. I'll do my best to answer questions. Sometimes I'll have to give generalities, certainly because the information that would be most helpful to you is going to be really specific to your situation, but I will certainly do my best to help respond to those. Let's see here. So, hi, see a couple people coming on. If you want to give us a shout and let me know where you're from too. This is my first time doing Facebook Live, so thanks for joining us and bearing with us. It'll be fun to see where everybody's giving us a shout in from. A couple of questions from people that we got earlier on was, what does therapy look like for OCD? I should probably start with, what is OCD? Probably most people coming to this Facebook Live event are aware, but obsessions are intrusive or unwanted thoughts, feelings, or urges that people experience as distasteful, disgusting, anxiety-provoking. So it's really this kind of unwanted experience. And sometimes people think that it's only an obsession's just a thought. It can certainly be, hi in Chicago. It can certainly be like an image also that could come into your mind. For example, sometimes people might imagine that they've run somebody over and kind of have this flash of an image in their head, or they might also have the thought, I ran someone over. So obsessions can look a couple of different ways. And then certainly there's the compulsion part, which is the effort to mitigate, get rid of, reduce that anxiety because it's so distressful to have that anxiety experience that's triggered by the obsessions. So coming back to kind of what therapy looks like, most of us who have been trained extensively in working with obsessive-compulsive disorder will, oh, hi, it's in Australia, that's great. So most of us who have been trained are going to be approaching it from exposure and response prevention. Let me know if you guys have heard that. Let me give you a shout out too. Exposure and response prevention is basically we're going to expose you to the triggers for anxiety. We're going to trigger those obsessions because we kind of need to activate that fear response, that anxiety or disgust response you're experiencing, in order to help your body learn that anxiety is normal and this will eventually kind of fade. And then we have the response prevention part. Now this is really key because if you think about it, you're going through your life naturally triggered all the time, right? There's not a day that you probably aren't going through already getting triggered. So you're like, I've got this exposure part down already, but why am I not learning from it? It's really about response prevention. So response prevention is where we come in and we say we're not going to do the compulsions. So again, compulsions are the things that you do in response to the anxiety and the distress that, you know, they're there for a reason. In the short term, it makes you feel good. In the short term, it helps reduce your anxiety, but long term, it prevents you from learning that the trigger wasn't actually dangerous in the first place. So with the exposure and response prevention, we're going to help you set up exposures and to trigger the anxiety, and then make sure that we prevent the compulsions, or sometimes you'll hear them described as rituals, from occurring. So maybe going back to that example I gave earlier, a lot of people tend to connect to this one, is that idea that I have an obsession that pops up, that I have hit somebody and maybe killed them with my car as I was driving by. And so what we might do for an imaginal exposure, for example, is to have them imagine that every time they're in the car that they have hit somebody, and then to not do the response prevention of say, and we'll ask what are your compulsions, what is the things that you're urged to do to make yourself feel better, or to like reassure yourself that things are okay. So you might say, I want to go back and drive my car back over the same path and just double check and make sure, or I want to look in my rearview mirrors. So I might have them practicing imaginal exposures, that they're driving and they hear an odd noise, and maybe we'll play some background music, like kind of noise in my office or at home when they're practicing, and they have to imagine that they keep driving past that. Or if we're in the office, maybe somebody will go out and they'll take a drive and we have to do the loop and they can't go back and check. So we're trying to do response prevention there. Let's see. Yep, this is the live session that began at 1:30 CST, kind of answering some of the questions here. And that's an interesting question. I've heard that ERP alone isn't enough, even if all compulsions are cut out. So I have found that, yeah, ERP is the most effective for most of the people most of the time. So as a provider, that's going to be the way that I train. I'm going to use the science to tell me where to start. But everybody is an individual. So there are different therapies out there and different approaches that can augment the therapy or help enhance it. Usually I find that most of my clients really want to start with exposure and response prevention, but again, there are other therapies or other versions that can be incorporated, like acceptance and commitment therapy, mindfulness-based therapies. So there are different ones out there. But again, usually after kind of educating my clients, will want to start with exposure and response prevention. But I think it's also key to like do response prevention. Mental compulsions are something that people are really good at and don't even realize they're doing. So I've had a lot of clients who have come to me and said, you know, I've done ERP. I got better, it improved, but it never really got me where I wanted to be, so I'm seeking additional treatment. And then when our first couple of sessions, I'll run through with them doing an exposure, and I'll quickly realize maybe they're doing a mental compulsion. So then I will teach them a subtle way to try to block that mental compulsion from happening, and all of a sudden they're like, oh, okay, something different happened this time. I didn't do the compulsion. I felt the uncertainty. I felt the anxiety come down over time. So, for example, like one way that I do that is I'll tell them to say the obsession out loud. It can be a really subtle way of kind of interrupting the brain process, because it's hard to say out loud and think something different. It's too much cognitive load, too much happening in our brain. So if we kind of add that burden of saying it out loud at the same time, it'll be harder to do some sort of internal compulsion, something like perhaps praying to yourself, reassuring yourself, telling yourself that I'm okay, I'm okay. If you're actually saying it out loud, it'll be a little harder to do that. So that might be a way to really try to enhance the exposure and response prevention exercises to get the most out of them. Okay, great. Looks like we have some people from Ohio. Looks like there's some more comments there. ERP for real. Let's see. Do this. Okay. Herd acceptance can be the missing key when ERP isn't enough. Yeah, definitely. I think a lot of my clients we've moved into kind of, once we really understand exposure and response prevention principles, that the idea of acceptance can be really helpful. And I think for me personally, the way I describe it is it goes back to even the DSM-5 definition of an obsession, which is this is a small version of it, but there's a very thick version that describes criteria that need to be met in order to diagnose OCD, depression, many other concerns. And it's really about the description to me from an obsession. An obsession is something that is unwanted by the individual. So when we're kind of resisting our emotions, our thoughts, we're labeling them as bad, then we're going to interpret it as bad. And we're going to feel worse in reaction to that. Versus somebody who might not have OCD has the same thought, oh, did I just kill somebody? They might not smile after it, but they might have that same thought, but go, just a thought I had today, and kind of move through their day. So they're accepting it, they're not judging the thought for being there and saying that it's a bad thought, I shouldn't have had that thought, or it said something bad about me. Instead, there's a little bit more of an acceptance level. But I find that exposure and response prevention can be really helpful initially too for just reducing the level of distress, and it makes it sometimes easier to think about that with it later. So I think earlier I was talking about what does therapy look like. So let's back up to the first session, because I think a lot of people get, or even further, the first phone call. I think a lot of people get nervous at that point. They know that something's going on in their lives that they could use some help with and want some help with. Just call. It's fairly easy. Just call or text, depending on the agency that you're working with, or the group that you're interested, or the individual you're interested in working with. I have people that when I'm at my private practice, they just call me direct, and I call them back and say, tell me what you're interested in, tell me what you're calling me about. And we'll just talk for a couple of minutes, and I'll get them scheduled for their first session. The first session is usually a 60 to 90 minute session. Is pretty typical, where we'll send you some paperwork ahead of time, just consent forms, release of information, maybe a couple questionnaires, stuff like that. And that allows us more time than when we meet to actually be really getting to know you. When you come in for your appointment, we'll come greet you very happily and bring you back. This is my office here, to give you guys an idea about what an office might look like. Hopefully a warm, comfortable setting. That otherwise you can also do telehealth too, where you meet virtually like this, and then you get to be in my virtual office, I suppose. But that first appointment, we're excited to meet you. We want to learn what's bringing you in to see us, and we'll do assessment from what we call like a biopsychosocial approach, where we're asking you questions about your biology, your physical symptoms, your medical history, that sort of thing. The biopsycho part is going to ask you about psychological symptoms. So what are your obsessions like? What are your compulsions like? And we'll help you figure those out, or ask you questions about it as well if you're experienced. I'm going to be helping ask questions like, when you need reassurance, how do you get that? When you're experiencing doubt, how do you make yourself feel better? And then usually we'll have you do questionnaires, like the Y box is a really commonly used OCD questionnaire that hopefully you'll get some sort of questionnaire when you go. That's another way of tracking symptoms, in addition to just asking you also how you feel. It's nice to have kind of like a standardized way to be tracking your progress. And then from that first the social part is learning about your supports, learning about where you might be having any issues in relationships or have strengths in those relationships to help you through progress in your treatment. So we're going to take our symptom assessment, our biopsychosocial assessment, and again, this is most providers, but probably not all. We'll add in other pieces. And then we are going to give you our diagnostic impressions. Do we think this is OCD? Do we think this is maybe generalized anxiety, panic? Is it something else? And then discuss with you your individual treatment plan, which may include exposure and response prevention if we are looking at OCD. So, and then kind of from there, usually we finish up our assessment in case we have lingering questions over the next 2 to 3 sessions, where from then on you'll either come in twice a week or once a week, depending, usually in the beginning at least, to establish the relationship and just let's get things rolling. Why wait, right? You've already waited long enough to get your appointment. So from there we set up your treatment plan, which might have, louder, yeah, please, I will definitely be louder. Which will have a hierarchy probably of the things that make you feel anxious and trigger anxiety, and then you'll break those down as you go through treatment and start doing the exposures. So trying to look at some of the questions here, because I could go on about treatment for a while. How do I book a virtual session? That's a great question. It's pretty easy. You kind of call and you just ask if they offer telehealth. That's usually the most common phrase that you'll see. Actually, NOCD does offer telehealth in select states. Right now, we are working our best to become available to everybody. But you could try going through NOCD. We offer assessments and therapy using exposure and response prevention. Otherwise, if you're looking for private practice too, you would just call your insurance company, make sure that they cover telehealth, or ask if they do. Otherwise, out of pocket might be an option too, but certainly understand that can be a challenge. And for my sessions, usually I have a platform that is HIPAA secure, and NOCD has it as well, so that's going to protect your confidentiality. So you want to make sure they do have a HIPAA secure platform. But you're just able then to meet over telehealth like this for your sessions. I actually find that it works even better than I would have thought for OCD, because the triggers aren't always present in my office the way that they're present in your home or at your work, at your school, wherever you may be. And so what's nice about telehealth is you can kind of take me with you as your therapist, and we can actually do like stronger exposures because you're actually in the settings. Looking at some of the, I am loud enough. Thank you. Thank you. I don't want to be yelling at you guys. Let's see, can OCD feel extremely real? I'm looking at expanding that question. For example, I'm not having thoughts as frequent as before, and they haven't been producing much anxiety or no anxiety in some cases. Still feel like things might not be right. Yeah, and self-diagnose. So it worries me a lot that I'm just lying. Oh, yeah, so it can be, I really do recommend meeting with a mental health professional if you're able to talk through your symptoms, and get their professional opinion about their educated professional opinion. Make sure that they are educated on OCD by asking them questions about what is their experience been, have they been supervised, what approaches do they use. But I do recommend getting an assessment, because that is a really common obsession actually, is my OCD is not real, I'm making this up, I don't really have a problem, do I have a problem? And you can actually do exposure and response prevention with those doubts as well about even is OCD really a disease? So I do recommend going and getting an assessment, even if you aren't sure about therapy yet, just even committing to that one time, going for an assessment, get a diagnostic impression. But from there, I think that, you could do ERP even around doubting if you have OCD. So you might say to yourself over and over again, I may or may not have OCD. And then kind of sitting with that anxiety or that discomfort that it produces. And then again, response prevention, preventing yourself from Googling to check, or from asking anybody that you have shared with that you might have OCD, prevent yourself from asking them if you have OCD. So also be some ways to come to mind. But I even have therapists who call me to consult, and they're like, I don't know what to do because they now don't know if they have OCD. I'm like, that's still OCD. You can still look at that as an obsession and treat it. Let's see. I haven't done anything as far as OCD goes with doctor other than meds. Been dealing with it on my own. Trying to tell myself nothing will happen. Feel like it's getting a little bit better. Oh, that's good. Yeah, so OCD waxes and kind of wanes if it goes untreated. Unfortunately, for most, it doesn't spontaneously just kind of really improve. So I do recommend treatment. If you're, not sure kind of where to start, to again, give us a shout and let us know too if you've downloaded the NOCD app. Part of what I love about our NOCD app or our website is there are tons of resources to help you feel educated, help you feel like you better understand what OCD is, and then also feel more connected to people who and can identify with people who might have it through our community. It's such a great resource. A lot of my clients, after they go check it out for the first time, they come back and go, this is awesome. The shame has been lifted and I feel better. Just even from that perspective of feeling connected. So I would, recommend, even if you're trying to start with like some self-help, there are some great resources out there as far as books. The NOCD app has great information on it, along with the website. And we also have free ERP tools that are in the app that you could start practicing exposure and response prevention. But certainly if you find that it's not improving or it's getting worse, then, go check out getting an assessment, whether that's through NOCD or local provider. We're here for you. We want to meet you. We are excited to have your phone calls when you're and then meet you when you're coming in. Let's see. Couple of questions about. Oh yeah, again going back to medication. Usually that's certainly an individual approach, and I would recommend speaking with your physician if you haven't already. Opening up to them about, I've been having these intrusive thoughts and or I've been having these compulsions, these things I feel like I really have to do, and they'll want to be helping you with that as well. Selective serotonin, serotonin reuptake inhibitors, or SRIs, are the class of drugs that are usually prescribed to help with symptoms of OCD. I think this is a very individual thing to go talk to your physician. I'm not a prescriber, so I can't really speak to that in much detail, other than, there's several SRIs that can be helpful. So, if one isn't working, not getting you the result that you're looking for, talk to your doctor, see if there's another SRI you could try or something else. It's important to be assertive and share with them. A lot of providers love to know that you're in therapy as well. We certainly want to, help you get better with all the resources that we can give you. So I don't have a ton more to say about medication, or that I can say without knowing a person specifically, but do want to mention that don't be afraid to talk to your providers about it, including your therapist, because sometimes people are nervous to say, oh, I know you don't do medication, or you might not believe in it. Like, we want what's good for you, so let's talk about your options, including even if it's just a consultation to find out what your medication options are. Let's see, here's a question. If somebody has obsessional thoughts that cause avoidance behaviors, does the person have OCD? Thoughts are intrusive and distressing, but the person deals with his anxiety by avoiding doing his work rather than performing a typical compulsion. Avoidance is a typical compulsion. Yeah, so I would be wondering if that person has OCD. I would be assessing further with them. If they are having an obsessional thought, image, or impulse that is then causing them to react, including avoidance, that might be a compulsion. So I would certainly be asking more about that. Let's see. Well, thanks, Ben, for saying I'm doing great. I appreciate that feedback. I like a little reassurance once in a while. Why isn't OCD talked about and referred to as the silent illness? Yeah, that's a good question. I think there's a lot of shame, and OCD is misunderstood. I also feel like as a system, kind of going back in our educational system as providers, we don't get the training that maybe we should have. I was really fortunate to have been in an anxiety disorders lab with people who did research on OCD and related disorders, had the chance to go train at AMITA and get that really intense experience. Unfortunately, a lot of us aren't even really given the opportunity to do that early on in training. So, hopefully we'll help advocate for that and change and get more and more providers exposed and understood. But I think too that, from our perspective, we have more to do. And I also feel like, there's wonderful organizations out there like the International OCD Foundation that is helping with this, and NOCD. We are really trying to get out there and improve the word. I think that it helps to know that there's thousands and thousands of people in the community, so that hopefully the community isn't silent. So hopefully this wouldn't be known as that much longer. Let's see here. I'm kind of looking at the questions. How do I do exposure and response prevention for throat OCD if the symptoms are not there all the time? Good question. And let's see. So I think I certainly would want to do more of a functional assessment with anybody's obsession to understand like what are the triggers, when is it happening. We'll do self-monitoring a lot for the first couple of days or the first week to help you track and better understand what's happening. But even if something isn't happening all the time, you can do kind of like intentional exposures where, and again, there's not details here, but like, say it feels like the throat is closing and you get some like somatic symptoms. Maybe what you might do, if the throat is closing due to like say dry mouth, you could do a live Facebook event and talk for a half an hour and try to evoke some of that dry mouth feeling. For people who might be having something like their heart racing a lot during their obsessions, and that's something that they feel uncomfortable with, and then want to do compulsion to make their somatic or physical symptoms go away. We might actually do like jumping jacks in my office before then we trigger the thought of I ran somebody over. So there are ways to kind of activate the physical symptoms, and if you can combine kind of your physical symptoms with your thoughts, with an image, with a sound, with a smell, like the more kind of sensory and real you make something, probably the more effective the exposure will be. So it's not that something you have to wait for an exposure to naturally happen. You could certainly also do imaginal exposures as well as trying to evoke some of the physical symptoms. I mean, I've had people laying on that couch who had like chest tightness, and I'll hand them like all my books from over here, and we'll just kind of keep laying the books on top, not till it's too discomforting, but till they get that pressure feeling, and then maybe we'll start another part of the exposure to get them triggering the thought like, I'm not going to be able to breathe and deal with this. So there are lots of ways, and that's again where it's kind of nice to have a provider who has some experience, at least to get you going with ideas and think really creatively about how to do exposures. Relationship OCD, that one comes up a lot. Jumping in relationship exposures, jumping from moment to moment. Exposures with relationship OCD are a common occurrence in this office, so it's certainly a common type of OCD. Again, we could get into discussion about types, but it does help, I think, some people to feel like they identify with others when we talk about different subtypes of OCD. So for relationship OCD, usually that's when you doubt your relationship, doubt your love, doubt somebody's love for you, and it can go in a bunch of other themes too. Usually what I'll do, if somebody's willing, is we'll bring in their significant other with them and educate them first about OCD and about exposure and response prevention. And sometimes we'll then start doing exposures where whenever the person thinks, I'm not sure if they, if they're worried that the other person doesn't love them anymore and they've been seeking reassurance, that's the compulsion, say. And they might text them throughout the day or call them several times. Maybe what we'll do for an exposure that week is have them, whenever they think that thought, do response prevention, where they're not then allowed to text or message or call and ask that. So we'll do that kind of naturalistically. Whenever it does pop up and they feel triggered, then their response would be no response, right? That they're supposed to sit with that anxiety and not seek reassurance. And we might even do some like in vivo or real life exposures where we'll tell the significant other that we're going to do exposure for the week, where they tell their significant other, I may or may not love you this week. Difficult, but again, it helps them. Usually people come back and they're laughing, saying, I can't believe that. But they can't laugh about it until they stop doing the response prevention and kind of distance themselves, kind of diffuse from the obsession a little bit. So that would be kind of examples of different ways that you can do exposure and response prevention with relationship OCD. But again, there's lots of ways to be creative and hopefully get the support of the significant others or family members involved there. Let's see. A lot of questions. I love this. For stuff that we don't get to today, because I think we are up on time. We'll hopefully take some notes and come back next time, which actually, please feel free to send us at info@nocdhelp.com to questions that you have for future events like this, because I know we could only do so much today. And let's see, one of the questions that came up is, do you give therapy over the internet or is it somebody else? In my private practice, I do offer telehealth, and in my role with NOCD, I'm the clinical director, so I'm helping train the individuals who would be giving you telehealth, and then I'm always available, love to consult with them directly on the care that they're giving you, along with our Chief Medical Officer, Dr. Jamie Fusner. We're both we tell our pros, we call them, our licensed mental health professionals, to don't hesitate, call us, ask us questions, consult, because we want to give you all the resources that we can from our team. So we do that quite often. And let's see, maybe one more. Somebody who's writing here, ERP works, but it's a lifelong process. Yeah, my hangups have been the fear that if I do something or don't do something, that something bad will happen to someone I care about. Not sure how common this is. Yeah, it's common, Randall. Yeah, it's responsibility kind of themed OCD is really, really common. People also feeling like responsibility that they have to even get better for other people too. So it can get very complicated. And I agree with you. Thanks for sharing. It is a lifelong process. Hopefully it becomes more like second nature the more that you do it. It is like a muscle that you have to strengthen that maybe you haven't used before, or if you haven't used it in a while, you need to re-strengthen it again. So I have people who will even see me in treatment. They'll feel great. They decide they're ready to wrap up, and I'll see them maybe for like our, booster sessions every once in a while too, every couple of years even. So don't be afraid to do that as well, because, life happens and therapy isn't going to prevent life from happening, but it is hopefully going to help you feel more capable of recognizing what's happening when you're experiencing it and feeling more confident being able to handle it when it does. And also confident that you know what works for you, which I think is important too. Like, I love when people are good consumers of therapy. They know it works for them. They know ERP works for them. Do it. Wonderful. It was really nice meeting everybody today. I think that we ran over time. Today went by much faster than I expected. Thank you so much for all the participation and all the questions, and I will hopefully see you all again soon. Thanks. Have a great day.